Everyone, welcome back to another weekly CPC. We got a fun case today, and the case today is the case of a 35-year-old female. Past history, it's a long one. FSGS, complicated by ESRD, had a living donor kidney transplant and complicated by graft failure due to rejection. Who presented with fevers, nausea, vomiting, diarrhea. Our expert clinician today is Dr. Stephen Chi. So by way of introduction, for Dr. Chi, he is an assistant professor of medicine in the division of pulmonary and critical care medicine. He did his undergraduate at the College of William and Mary, and then came here for WashU and has stayed here since for medical school, residency, home crit fellowship, and palliative fellowship as well. So going on to the one-liner, it's a 35-year-old female, past history of, it's all bad, it's a lot of words, presented with fevers, nausea, vomiting, diarrhea. I will turn it over to you for your initial thoughts.
Yeah, geez, this one-liner, man. This freaking one-liner. So you gave me a lot to mull over with this. Thank you so much.
You're welcome.
This is my recompense for, questioning some of my residents on rounds. I'm here for my public drubbing. So if I take this one-liner at face value alone, yeah, I'll take it, sure. If I take this one-liner at face value alone, then what you've given me is a young patient with a solid organ transplant, and therefore immunosuppressed, coming with fevers, nausea, vomiting, and diarrhea. And so the differential for that, an immunosuppressed patient coming in with GI symptoms, of course, like first things that comes to mind would be an infection. And there's many common ones still being common even in immunosuppressed people, but just like a regular gastroenteritis, a norovirus case, which would be very boring for CPC, adenovirus, one of the many other enteridities, infection enteridities that can certainly plague just you and I, but also someone who's immunosuppressed. But then there's a bunch of other like CPC favorites, like things like defendant viremia, disseminated fungus, like histoplasmosis. I threw out Whipple's disease just because I think it would be fun, and I still haven't seen a real case of that. But as depending on the time course of these symptoms, which you didn't give me in this one-liner, even though you gave me a whole bunch of other things, my concern for other etiologies besides infection would increase. So if this has been going on for a subacute period of time, for like days to weeks, or even going on to months, becoming more of a chronic thing, then I get more and more concerned about things, autoimmune etiologies. Inflammatory bowel disease being still the most common of the things that I've listed here, but CPC favorites, including HLH, one of the many vasculitides, of which you guys have had so many in the last couple of months here at CPC. And then TTPs, MAHAs, I'm assuming she's probably on tacrolimus, which predisposes to a MAHA. But she could just have hemolytic uremic syndrome, and that may certainly explain the GI symptoms she's having now. And then lastly, if she has some kind of malignant process, she's young, but on immunosuppression, anything is possible. And so a post-transfer lymphoproliferative disorder would be certainly something to worry about if she was having these symptoms for going on for weeks or so. Hopefully with other systemic symptoms too. Gut adeno is unfortunately rising in prevalence even among young people, whether they're on immunosuppression or not. Amyloidosis, again, you guys have had way too much of that. And I didn't put this down here, but something like graft versus host disease will be very unusual in a kidney transplant because there's just not very much lymphoid tissue that gets transplanted with a kidney, as opposed to like the heart or the liver. But technically that'd be something to worry about too if she had gut GVHD. This one-liner was very long, and I just want to point out that I think it's well established that you guys cater your cases to whatever specialty of the discussant that's coming up. So the hepatologist gets liver amyloid, the cardiologist gets cardiac amyloid, and the infectious disease doctor gets disseminated endocardia or whatever. This person, is not coughing, it does not appear to be hypoxemic, and isn't, dead. So thank you for catering to my specialties with this.
It will cater to your specialties soon. You'll see.
Oh, great. Awesome. Fantastic.
Last I checked, you are a critical care physician. So.
I am a critical care physician. I do think that it would have been hilarious if you had presented the first ever CPC case of cardiac death. I think that would have been phenomenal. You can't get that many hospital care doctors doing this, right? Anyways, you gave me more to mull over though, like the fact that this person has graft failure secondary rejection. And so while I just went over the differential for fever, GI symptoms, and immunocompromised host, the problem is you told me this graft is failing. You didn't tell me how much it had failed. Because if you're in the midst of graft failure, then oftentimes you ramp up the immunosuppression to try to salvage whatever function you have left in it. And so, you might be getting pulse or steroids, you might be getting things like IVIG, all this other stuff. But the kidney is the only solid organ transplant where if it fails, you don't necessarily die, right? Like if your heart transplant failed, you're gonna die. If your liver transplant failed, you're probably dying. But if your kidney fails, you just put them back on dialysis, and then over the period of months to years, oftentimes those people are taken off of their immunosuppression entirely. And so all this stuff about immunosuppression may actually be a completely moot point thanks to your, lack of other information in this one-liner. Additionally, because you told me that this is from rejection, that raises the question in my mind, does this lady have compliance issues? Was she not taking her tacrolimus? Was she not taking her prednisone? Or does she have some other concerning behavior like that may have led to the rejection as well? And if she wasn't taking her immunosuppressant medications, could she have some kind of opportunistic infection if she wasn't taking her prophylaxis, if she wasn't taking her Valcyte or her Bactrim? And then you also didn't tell me whether this FSGS was primary or secondary, because primary FSGS would be, fine. I'm not going to put too much thought into that. But if it was secondary to something like HIV or hepatitis B or hepatitis C or heroin use, that also changes my differential quite a bit in terms of what I'll be most concerned about. So, thanks for all that. So the questions I would want to know, especially if she's being presented to me as a critical care doctor, would be just how bad and how fast do these symptoms come on? Is she super sick? Is she in my ICU already, or is she just coming in for an outpatient workup? I want to know exactly what you mean by graft failure, whether this person is still on immunosuppression or not. I want to know what other symptoms that she would have. And of course, I imagine someone with FSGS who's been through a kidney transplant has a lot of other comorbidities too. And so I'm very keen on knowing what those are.
Awesome. Thank you for that. Comments about the one-liner aside, what I've given you. I did do the very first CPC for this academic year, and the advice I got afterwards is you gotta make them sweat just a little bit. And so I think I made you sweat just a little bit, but your questions will be answered very shortly.
Gee, thanks.
Yeah. Okay, so for the HPI, she started experiencing nausea, vomiting, water diarrhea, and malaise about 1 week prior to presentation. So this is a fairly acute presentation. She also just endorsed this general feeling of not feeling right, and mental clouding. Over that week, it progressed to lethargy and worsening mentation, leading to her mother actually calling EMS because of her worsening mental state. Her mom also being there helping her out, had noted that she had a fever to 101 degrees Fahrenheit the day prior to presentation. But then after arrival to the ED, her mentation continued to worsen and she became obtunded. Because of that, they were concerned for airway protection. At that point, she was intubated and transferred to the MICU. Before we have comments on that, I did go through all of her kidney history because it is actually fairly complex. So I will go ahead and go through that. So this started about 12 years prior when she was pregnant with her twins at 22 weeks due to proteinuria and hypertension. She delivered her twins at 35 weeks, but then afterwards experienced postpartum acute renal failure, but only partially recovered. And so her creatinine stayed in the 2s. She did not require dialysis after recovery. She just during that process. Sometime after that, she had a biopsy that showed FSGS. I can't give you more than that. I'm sorry. I could not figure out more than that. 1.5 years prior to this presentation, so now this is about 10 years after this initial insult when she was pregnant, she underwent transplant from a living donor, happened to be a friend who was surprisingly pretty compatible with her. At a 1-to-1 mismatch with regards to HLA, CMV was positive in both her and the donor, and she was positive for EBV and ABO compatible. About 9 months after the transplant, so about 9 months-ish, 9 months prior to presentation, she was known to have subtherapeutic attack levels and double creatinine, though she reported adherence to immunosuppression as prescribed. She was on tacrolimus and prednisone at that time. They got a biopsy of the donor kidney, had acute cellular rejection and moderate interstitial fibrosis. They gave her some more steroids with a steroid taper, the dose of thymo, and the long steroid taper. 6 months later, so now 3 months prior to presentation, she again had a worsening creatinine and admitted to metformin. They suspected repeat rejection. They got the donor-specific antibodies that were positive. At that time, she received a dose of rituximab, Cymedrol, and another steroid taper. They also started her on mycophenolate, and I'll comment about that in just a moment. At that time, she had plans to get a PD catheter. She saw her transplant nephrologist. There was discussion in notes about saying, hey, I'm gonna get a PD catheter placed, but canceled the appointment because she was not feeling well, this again, about 3 months prior, and did not reschedule. The next thing we have is that she then presented to Barnes for the symptoms I discussed in the previous slide. So now that we have more information about the HPI as well as the transplant history, how does this shape your thinking with regards to the patient presentation?
Can't express my joy to have so much to read here. So, you presented still some of GI symptoms, systemic symptoms for about a week, and then who became obtunded on arrival, necessitating intubation. In the context of immunosuppression, I would be very concerned that she would have some kind of meningitic picture to explain all that, whether viral or bacterial, which could present atypically given how much immunosuppression that she's clearly on with this. Something else that would explain mental status changes as well as worsening renal function as well. These GI symptoms would be something like TTP or MAHA, like I mentioned earlier. Although she could also just still have some other systemic viral or bacterial infection that would also cause septic encephalopathy. And unfortunately, while we invoke septic encephalopathy for many of our critically ill patients, I mean, the truth is it probably is responsible for most of our patients getting obtunded and needing to be intubated. This transplant history is interesting in that like this person has clearly been very heavily immunosuppressed and blasted with things like solumedrol, thymoglobulin, rituximab. And so that significantly raises my concern that she would have a opportunistic infection over something like a PTLD or over some other kind of malignant process or autoimmune thing that you'd think would have been treated by all the stuff she's getting. Although the fact that you mentioned the subtherapeutic tacrotroph and reported urine stain suppression still makes me wonder about the compliance in between her being in the hospital, especially since she didn't get her PD catheter placed like requested. And so unfortunately, this is still giving me a mixed picture of either this person's on all the immunosuppressives or this person's not taking immunosuppressives, and that that doesn't help very much. So thank you again for that, Dr. Daniel.
I'm just giving information as it is. I think it's safe to say that at least within for the last 9 months, she's been receiving a significant amount of immunosuppression. And based off all the notes and all the, of course, the medication that she received. We'll transition to her past medical history. In terms of the rest of her history, in terms of the medical history, the big things are hypertension, hypothyroidism, and migraines. The surgical history is, of course, the living donor kidney transplant she had previously, but no other significant history. She has this rash, develops a rash when she takes Bactrim. Medications you can see over there: amlodipine, aspirin, vitamin D, Synthroid, prednisone, propranolol, sodium bicarb, kind of in context of her worsening kidney function after her graft rejection and TAC. I put mycophenolate question mark there because when she saw her transplant nephrologist, the note said that she was supposed to continue mycophenolate. However, on presentation to Barnes, there was no mention of her being on mycophenolate. It was not in any of her active meds at that time, and it seemed like she was not taking it. I have no idea what happened with the mycophenolate. I was trying my best to figure it out. I was going through like a little meds tab that we almost never use, and they just said discontinued. I really don't know. So
while you're going through that meds tab, can you tell me what happened to her opportunistic infection prophylaxis? She
I
wasn't on
apologize for that.
Bactrim. Was she on?
Yes. She was, I apologize for not mentioning that. She was on Valacyclovir. I cannot, and she was on PJP prophylaxis as well. I'm apologizing.
With something that wasn't Bactrim.
Correct.
Okay.
Yes.
Okay.
And then social history, she does not smoke, drink alcohol, or use illicit drugs. She lives in Salem, Missouri. For those of you who don't know, it's about 30 minutes southeast of Rolla. In fact, you know what? I go ahead and put a map on here because I was curious. It's there. So we are here. They are there. And that's Rolla, for those of you who aren't aware.
Are you trying to point this out to say that she lives in somewhere like more rural next to a national forest, or are you?
I'm just saying that she lives in Salem. I got
a lot of chicks in Salem. Okay, all right.
Okay.
Moving on.
All right, we'll go through the review systems. Positive for most of the things here. The stuff we mentioned, but fevers, like I said, she just doesn't have poor appetite, leading to weight loss, malaise. She does have this non-productive cough that developed in the last couple of days. The GI symptoms, as previously reported, and then this quote-unquote brain fog. Everything else was reported negative, though. At this point, given her mental status, a lot of this was attained via her mother. So at this point, what are your additional thoughts before we go on to the objective studies?
I mean, you've given me a lot of loose threads to tie together here. If I had to use the CPC logic to look only for the zebras, then I'd be worried about things like a tick-borne disease, Rocky Mountain spotted fever, for instance, that would cause this degree of lethargy as well as headache or not headache, as well as ultramental status. Although, again, septic encephalopathy from some other disseminated infection would be my big concern. You were so dodgy about the OI prophylaxis, it really makes me wonder about this whole CMV or EBV history that you gave me as part of her renal transplant history. Well, could she have had reactivation in the setting of all the immunosuppression that she got recently to explain CMV or EBV viremia, therefore leading to the rest of her symptoms? And then, of course, just other types of disseminated infections. Again, given the acuity, my concern for an autoimmune or malignant process would be much lower, and I'm now starting to think about all the various types of infection that this person wasn't prophylaxed against, you know, considering that Bactrim prophylaxed against, for instance, toxo and PJP, and if she was getting some alternative thing for Bactrim alone, she may have not have been prophylaxed appropriately against toxoplasmosis, which tends to go to the brain. So
that is correct.
Thanks. Anyways.
So let's move on. Those are all great thoughts. And so let's learn from the physical exam. And so I do highlight here her temperature of 38.6, but the rest of her vitals are stable. She is not Hypotensive, no need for pressors. I apologize. Her Venn settings are pretty minimal. Let's say she's on 6 cc's per kilo in terms of tidal volume, breathing 16 times per minute at SpO2 100% on PEPA5 and 40% FiO2. Otherwise, she's obtunded, intubated, and everything else is, in terms of the exam, is fairly unremarkable, as we would say.
Interesting.
Any other thoughts?
No, this is not
Fair.
very, I mean, the lack of rashes would rule out a lot of things that I would have been concerned about.
So
No suffusive conjunctivitis? No?
no conjunctivitis. This was
Okay.
taken from the note by our lovely ICU resident, and there was no.
That does not make it any better. In fact,
I
I'm going to
also-
distrust this even more now. So
I did corroborate it with the attending attestation too.
okay.
I will not comment.
That doesn't make it any better.
I will not comment on who the attending was. We could talk about that.
The
afterwards.
only thing I take from that is that there probably wasn't really any edema, but outside of that,
Correct.
yeah.
There was no edema. So, okay. I think we'll have a little bit more fun with the next slide. This will be the initial labs before we go to our choose your own adventure. So on presentation, creatinine was 7.26. During the previous hospitalization 3 months prior, it was more like in the 2s to 3s. So this is significantly higher than previously seen. BA1 was 44. The rest of the BMP part was relatively normal, except for that pretty high FOS, 7.9. On the CMP side, you can see there with their liver enzymes as well as the protein albumin are all all not within the normal limits in their respective ways. I'll go ahead and also give you her CBC. She had a white count of 0.7 with an absolute neutrophil count of 600, hemoglobin 8.3, and the platelets of 33. The white count and the platelets are the thrombocytopenia and the leukopenia plus neutropenia are all new. Her hemoglobin was roughly there, has been for some time.
Great. So hemoglobin, you said at baseline, thrombocytopenia and leukopenia new.
Correct.
And then how, like, the last labs were from 3 months ago when she was in the hospital
Correct.
then? Okay. All right, so we got certainly new bicytopenia with absolute neutropenia. We have mild AST/ALT elevations, which suggests perhaps like that she may have rhabdo or maybe was drinking alcohol, but the out of proportion AST always makes you think about rhabdomyolysis. And then creatinine being elevated in the person who was supposed to be on PD doesn't necessarily make me very excited, especially if they're planning on doing peritoneal dialysis. I can't imagine her allograft function is any better now than it was 3 months ago. So I'm not sure whether to say that that's truly an acute rise or whether it's just been chronic rejection that's still progressing here.
Mm-hmm.
Although the FOS elevation would also may suggest more acuity rather than chronicity. This particular pattern of pancytopenia as well as AST, ALT elevations always, of course, makes us wonder about tick-borne diseases. When you have like a mild alk-Phos elevation, that also makes you worry about infiltrative disease, something like histoplasmosis. Although generally, if it's going to be that pronounced, it's going to be a very disproportionate alk-Phos elevation compared to the transaminase elevations alone. The platelet decrease is low enough that makes me still wonder about a MAHA or TTP. Although TTP, generally the platelet nadir is less than 30K, but maybe that's going to happen in the next couple of days or not. If you have if you have a thrombocytopenia to this degree that's due to a drug-induced MAHA, then this would be more in the kind of range where I'd worry about like the tacrolimus causing it, for instance. Although it certainly wouldn't explain a lot of the rest of the symptoms. So
now we'll go to the fun choose your own adventure part. Here are the options right now. I do kind of want to get your insight into the studies that you would probably start off with. I think what may happen typically in the ICU is that they're in the ICU, we're going to order everything and just order Rainbow Labs. They're in the ICU. We don't know what's going on, just shotgun approach. I was kind of curious to see, like, in this patient, which do you think would be the more informative studies? We want to be a little bit more targeted with our approach. And you're like, Edward, I don't do that. I'm in the ICU. I just order everything.
that's not the okay. All right. Well, I generally like argue against the whole value-based medicine in the ICU, considering that the cost of an ICU bed alone is already what, like $8,000-$10,000 a day, and so value-based care is kind of silly there. Like, we should still target towards what we think is going on. Although in this case, an immunosuppressed patient who's obtunded, intubated, critically ill, you said the pressures are fine. With pancytopenia, I think sending things like tick-borne serologies would be very important. I think probably doing an LP to make sure that they don't have some kind of meningitic process would be reasonable, although it's going to be contraindicated by her thrombocytopenia, so that's going to be an issue. We'd have to see if she responds to platelets. Of course, we're going to get an X-ray since she's intubated, and I think I think sending the infectious workup to include standard blood cultures as well as looking for fungal serologies, especially since you showed me that map of Salem, would make me concerned that she would have some other kind of disseminated fungal process going on here.
Okay.
That would be my initial approach.
Well, we'll start with the chest X-ray because we got to do something with the lungs. So here is her chest X-ray after intubation. It's actually a little bit farther into her course, but.
All right, so we got an ET tube in the middle that looks like it's probably about 3-ish centimeters above the carina. We have a right IJ, what I assume is a dialysis catheter given the thickness of it. We've got a bunch of lines coiled over top of her chest, which looks like it's an OG tube as well as just a bunch of tele leads. Heart size looks probably fine. The lung parenchyma itself, there's, if you told me there was some increase like opacities at the right lower lobe kind of overlying, like near the hilar area, I would believe you, but otherwise I'd say this is a fairly benign looking chest X-ray.
Yeah. I don't have the official read, but that was what they said too in the read. Mostly commenting on the position and the tracheal tube and like, oh, this needs to be adjusted, yes or no.
It's not the clavicle.
So infectious evaluation, we'll start off with the usual, blood cultures, HIV, RPR, all this, respiratory virus, all that was negative to start off with, just to check that off. But you didn't also mention some other things. You mentioned fungal serologies, some tick-borne diseases. What else? Can you specify which tick-borne disease? You mentioned Rocky Mountain spotted fever, but anything else?
Rocky Mountain spotted fever would be one concern. Something just like ehrlichiosis or anaplasmosis. While anaplasmosis would be less common in this area, ehrlichiosis is, of course, a big concern in the Midwest. Someone's going to talk about Lyme disease, which is, to my knowledge, still basically non-existent here in Missouri. So unless you had some travel history that you didn't give me, I would not be nearly as concerned about that. And the babesiosis is, of course, something we always talk about in the same sentence as ehrlichiosis. Although I still only seen one case of that in my career. Sorry, did that answer your question?
It did. So the additional infectious evaluation did include in transplant ID consult. And so this is copied and pasted verbatim from the transplant ID notes. So she lives with her 12-year-old twins who are in good health, goes out to baseball fields, watch her son play baseball, visits a friend's farm, pets their cattle and mules. Mother isn't sure what other animals the farm has. She has a pet dog, healthy, who occasionally will kill mice, rabbits, and other small prey. Those are not healthy. No known tick or insect bites, but her mother will ask her children, who are 12-year-old. Fish mow her garden. The home flooded April or May. This is July, so about 3 months prior. The walls were torn out for renovation. The work was completed in May. No recent trouble and no recent travel to the Northeast, Southwest, or Upper Midwest, USA. So they did send off several labs. The EMV was consistent with past infection. The CMV is positive, but we knew that prior to her transplant. VZV, histo, blasto, cocci were all negative. You can see some of the work up there. Parvo, Lyme, Rocky Mountain spotted fever, and Francisella were also non-contributor. I guess Parvo was consistent with past infection. The others were negative.
Interesting. And that's just based on the VCA panel for the EBV, or did they also send a viral load too?
Just on the just on the panel.
The only thing I'll point out is that, like, did she get IVIG as part of her immunosuppression too? I know you mentioned rituximab, but
not IVIG.
Okay, all right, never mind then. IVIG would obviously screw with a lot of the serologies that you would get, and then with rituximab, it makes you question whether a lot of the antibody-based testing that she would have gotten as part of this would be still accurate. But
it is known that the EBV and the parvovirus were antibodies that were tested positive. So like the parvovirus was an IgG positive, IgM negative with it, and so there are some antibodies in there that are still cooking, even though and she only got one dose of the rituximab as opposed to the full loading dose series.
Fair enough.
Okay. The other studies the Ehrlichia and plasma are currently in process for now. What other workup would you like at this time? You kind of mentioned some things regarding her pancytopenia. What kind of workup would you get for that?
Well, I mean, of course, I always get nutritional studies on someone coming with pancytopenia because they're easy to send and they come back relatively quickly. Although a lot of people also often will ask me why I even send B12 in critically ill patients because there's an acute phase reaction. But every so often we do, in fact, diagnose someone with true B12 deficiency or folate deficiency. I'm sure she'd end up having like a retic count and a smear done. I'm sure she would probably end up having like an iron panel sent as well. Although in someone with end-stage renal disease, it's probably less useful there because you're probably going to find anemia and chronic kidney disease. I think the parvovirus that was sent was a good call, which I didn't mention earlier, but certainly that could explain some degree of anemia, like if they had aplastic anemia, but it wouldn't necessarily explain the thrombocytopenia and the leukopenia as well. And then, because of her degree of immunosuppression, if there wasn't something else that clearly came back positive on her labs, like I'm sure someone probably talked about doing a bone marrow biopsy on a lady like this who's having like new profound leukopenia who's critically ill. Although knowing our hematologists here, they almost certainly said no. So anyways, here we are.
Yeah. So it sounds like, check the iron labs, check the ferritin, B12, folate, check out, the hemolysis labs as well. Kind of do the whole gamut of all the.
Oh yeah, hemolysis. Yeah, that. Yeah.
Yeah, there you go. Well, anyways, we did all that. So her
Right.
ferritin was a little bit high, at a greater than 100,000. Her T-cell iron were aberrant as well. The B12 and folate were normal. In terms of her hemolysis labs, the haptoglobin was 322, LDH was 1296, indirect low was negative, and then her fibrinogen was low at 111. They got peripheral smear. This is taken. We did consult. They did consult hematology, and this is from their notes. I also have a picture of the neutrophil. If you in the next slide, but I'll let you comment on these numbers first.
So the LDH being remarkably elevated is concerning, although the haptoglobin being normal or high in this case would argue strongly against intravascular hemolysis. Same with the minimal to no schistocytes, which effectively rules out things like TTP or MAHA. The hypofibrinogen anemia and the very elevated ferritin, of course, raises concern for HLH, which I mentioned earlier. In which case, I'd be curious to see if she also had like triglyceride sense, and whether she had any imaging of her belly to indicate whether she may have like splenomegaly or something like that. That would point me more strongly that way. The LDH being so high really does make me wonder more, like if she has some kind of marrowsuppressive PTLD. It does make me wonder more if she has some kind of marrowsuppressive PTLD, which I had previously kind of poo-pooed given the acuity of this presentation. But with it being so high, it does make you wonder, does she have some kind of underlying lymphoma that would, or some kind of leukemia affecting her marrow that would have explained the pancytopenia, and then only finally came to a head in the last week to cause her to present? Yeah, those would be my initial thoughts.
Here is the picture of the neutrophil. If you happen to have grand insights based off the picture, which looks better on at least the screen compared to that, I apologize. No, if not, I 100% understand. This is according to the hematology notes and certain ID notes too. This is like, oh, looks like consistent with X, but there's also another test that's currently cooking that'll help you with it.
Yeah, this isn't like it doesn't look like a Babesia cross. Isn't that RBCs too?
Yes, the Maltese cross. Yes, that sounds familiar.
Yeah.
Med students here can help me.
That's an RBCs, right? Yeah, that's not a neutrophil. That's not an hour rod. That's not a, yeah, I don't know.
Sorry about that. Here we go. So I'll go ahead and say, well, in the meantime, the Ehrlichia and anaplasmosis came back, and she's Ehrlichia positive. So that actually were those intracellular findings were actually Ehrlichia that were being seen in the neutrophil.
Interesting. Okay, that's literally the Ehrlichia body itself. That's that little.
Yeah, apparently. I trust the hematologist to comment on that more so than my own knowledge, but that is what they said.
Weird.
How does this affect our thinking right now?
Who actually goes to the iWish to look at the slides anymore, right? It's such a trek to get there now. Like we can't do it.
Especially
on the weird looks when you like try to go there and ask to look at a slide.
This is why we consult hematology, and then they
tell us and then just look at television that they don't give us access to either.
I know, it's so nice. Anyways, after now knowing that she is Ehrlichia positive, how does this shape your thoughts?
It makes me very concerned that this lady has ehrlichiosis that may be causing HLH as a result of it, to explain her like systemic manifestations, in particular the very elevated ferritin level. The pancytopenia and the transaminase elevations alone could be easily explained by Ehrlichia by itself, as well as the obtundation, the fevers, the other systemic symptoms. It raises the question of like, how long ago did she have this? And is it truly like HLH? Is this HLH due to Ehrlichia that would mandate HLH-specific therapies, or can we just get by with treating her with doxycycline for long enough time and hoping she gets better? Those would be my thoughts based on having that positive alone. Although, of course, I'm sure infectious disease is weighing in at this point too about what they would want done.
Yeah.
So.
Any additional work? You mentioned triglycerides, so we can go that. This is my various special chemistry labs because this is under the special chemistry tab, and there are a few things here that I couldn't nicely fit in one. Cool. So here, the lactate, which she presented, was 2.2. It went to 1.0 shortly afterwards. Her cholesterol is there. Her total cholesterol is amazing at 76. Her triglycerides are elevated at 343. The LDL is actually said less than 1, but that's because it's a calculated version, and I don't know what it actually is. She did have a troponemia up to 6,200 that peaked at that point. Her NT-pro BNP is 41,000, and she had a CK of 6,500.
Okay. I mean, the rhabdo was certainly explained to AST over greater than ALT elevation. The NT-pro BNP and troponins, I mean, in a woman with end-stage renal disease who's had a kidney transplant, I imagine, and with worsening allograft dysfunction, just volume overload alone due to worsening renal function could certainly explain that. The troponemia presumably just is secondary to the global inflammatory state that she's in right now, as opposed to like occlusive coronary disease, or she could just have a septic cardiomyopathy. And then the high triglycerides, again, makes me concerned about the diagnostic criteria for HLH in this lady. So I think we've got triglycerides, low fibrinogen, high ferritin, we've got cytopenias. We haven't heard about splenomegaly. I still have no idea how to actually measure NK cell activity, so that's out the window. And I don't know if they sent an IL-2R on this lady, but
They did, among other autoimmune workup. And so you can see here the CRP is elevated, ESR, IgG is a bit low. The other ANA, ANCA, RF, it's not a vasculitis. And her IL-2R is 5,300 elevated.
okay. Well, I think that gives us 5 or 6 out of 8 of the criteria that we would need to make the HLH diagnosis. In which case I would say this would be HLH secondary to ehrlichiosis. It still makes it very challenging to know whether, would this patient just get better if you just treated the ehrlichia alone, or whether you blast her with etoposide and dexamethasone at the same time. I think it would just depend on how critically ill she was, or conversely, how stable she is, that you have the luxury of time to wait.
Yeah.
So,
to round things out, in terms of the imaging, she did not have splenomegaly. The other imaging here, just looking at just in the interest of time, looking at the ultrasound of the right upper quadrant ultrasound, which was normal, and then the transplant Doppler, that was also normal as well, commonly requested by a transplant nephrologist. So, any final thoughts with regards to it that you mentioned, kind of that you'd like to add on before we reveal the diagnosis?
it's an interesting case. I'm sorry for being hostile towards you earlier. This was an interesting case. I think from a management standpoint, I'm not sure about what the right thing to do at this point would be. Like obviously she's going to end up on doxycycline. We would watch her for a while, I imagine, to see if she responded. But like the secondary HLH like this is challenging because the HLH itself carries such a high mortality rate of like somewhere like 60% or something like that, where blasting her with even more immunosuppressants that presumably led to, predisposed to developing this kind of infection in the first place, doesn't really feel very good. And there's certainly a significant risk of making her worse with giving her etoposide. But yeah, I think it's interesting that she didn't have the organomegaly that I would normally associate with this. But I wonder if maybe how much all the immunosuppression she got before coming in blunted that response, that she couldn't actually form the, the germinal centers in her spleen that would have caused it. So.
That's all great insight. So the diagnosis for this lady is exactly HLH, secondary Ehrlichia infection. Excellent discussion. I think you made a lot of comments about kind of what the course would be depending on stability. This does end rather sadly. So she was started on cefepime for neutropenic fever when she first presented, then kind of quickly brought in with suspicion for meningitis, encephalitis. Early on. Once the Ehrlichia results returned, they transitioned her to IV doxycycline. However, very shortly after she presented, she experienced PA arrest. They achieved ROSC twice briefly and actually started CRT during the code to try to treat her hyperkalemia and acidosis. However, after an hour of ACLS, she remained at asystole, and they decided to stop further intervention at that point. So a rather sad story in this young patient and about that. So the teaching topic for today is HLH. So hemophagocytic lymphohistiocytosis, HLH, an aggressive life-threatening syndrome of excessive immune activation. So it actually occurs more often in children, and pediatricians are more attuned to that, but they, of course, can occur in adults. There are familial sporadic versions. This patient had the sporadic version. It typically presents acutely with multi-organ involvement. The organs are usually involved. There's the bone marrow, the cytopenias that we see, the liver, as well as a lot of neurologic manifestations, which is what happened in this patient. Triggers include infection, which is actually more commonly a viral infection compared to the tick-borne disease that she ended up having. Lymphomas, rheumatologic disease, immunodeficiencies, and in that also includes patients who are immunosuppressed from transplants. The differential is rather broad, and we'll go through the diagnostic criteria in just a hot second. But you have to make sure you rule out infection or sepsis, or determine if there is an infection, appropriately treat that. Liver disease, lymphoproliferative disorders, Kawasaki disease, stress, various MAHAs. There's a lot of overlap between them, but each of them have a slightly different aspect that will present, that will lead you toward either something in the differential or towards HLH. This is a very has a lot of high mortality, so prompt treatment with dexamethasone plus etoposide plus minus intrathecal therapy if it is indicated. Over on the right is the 2004 diagnostic criteria for HLH. It's actually been updated to the 2024 criteria. The big changes is that instead of 8, which is actually accidentally blocked off, it's 7 criteria below. So that low or no NK cell activity is no longer in the 2024 criteria. I have no idea what that means either.
I have no
but
idea
that's probably
how
why
they
took it
even
out.
measured it in the past. Like, I don't understand.
Yeah. Our patient had 5 of these. So fever, cytopenias, hypertriglyceridemia, and hypofibrinogenemia, though that's actually all within one. The elevated ferritin at the highest I've literally ever seen, and on repeat, that was true. And then the soluble IL-2 receptor being 5,500. So she met 5 of the criteria. I presume there probably would have been more workup, maybe even some molecular analysis. Unfortunately, the patient passed away before any of that workup could be done. So I want to thank you again, Dr. Chi, for your insight and your discussion, and thank you all for coming.
Thank you for having me.